We're in the beginning of a paradigm shift here in perio. Maybe not at the beginning. Maybe we're really in the middle of it. And of course, that's why you're members of the AIP. You want to progress. Paradigm shifts occur every place, in every aspect of life, and we're just tackling the paradigm in the way it presents to us today, so the patients have the benefit of seeing a periodontist. So let's talk about the 12 attributes of what at least I consider to be the director of dentistry. You may have yours, and I invite you to add yours to these attributes and just send them to us. You know, we could use some help too. So let us know what you think, but let's talk about what we think are the 12 attributes of the director of dentistry. So first comes training. Okay, training in the periodontal residency should expose the resident to all disciplines of dentistry to help the periodontal resident have a full view of diagnostic and treatment options out there. Case conferences should look at the total patient, the total dental diagnosis, and the treatment plan. So what does that mean? Essentially, it means that we need to expand. And by the way, many residencies do. Maybe all of them do. But we need to expand beyond the focus of perio and dental implants. After all, patients coming in to you for a particular reason. One of 4 reasons. They want to smile, they want to chew, they don't want to be in pain, and they don't want their mouths to stink. You're going to hear a lot about that because there are only four reasons, those 4 reasons that patients see us. So if we're thinking simply about regeneration procedures, grafting procedures, dental implants, and how to restore those dental implants, our focus is too small. We need to be looking at the entire mouth. And as a matter of fact, when we're going through a treatment plan, that's exactly what we're doing.
Yes.
So when we're looking at a total treatment plan, we've got to look at curve of Spee. We have to look at number of surfaces for a filling. We need to look at whether a buildup is required or not. We need to look at what the prosthodontist should do, not just a prost consult, but what should a prosthodontist do? What should the orthodontist do? We need to be looking at total responsibility for the patient. And if we're doing that, that allows us to become the director of dentistry. We're the director of dentistry. It's just not just a term. It's actually the patient is looking at the periodontist as the director of dentistry, as the coordinator of treatment. And each individual that you're putting into that equation, I'm talking about each doctor that you're putting into that equation, if the patient needs multiple doctors, is essentially working with you. So you're the architect of the mouth. Yes, you may have your subcontractors, and they may have certain things that they need to do, and by all means, we want their inputs, but the entire concept of director is yours, and that falls into the examination and treatment planning mode.
Does that apply to when patients are coming direct to you from on the street, or referral from a dentist, or both?
Both.
Okay.
Whenever a patient came into, I mean, I've been in practice for a few years, so you probably can tell. Whenever a patient was referred, yes, the patient would have a complete treatment plan. Well, you've been around when we were referral practice. Never a deviation from that. Always the complete treatment plan. Because if we don't have a complete treatment plan, or if I don't make a complete treatment plan, or if you don't make a complete treatment plan, who's going to? Okay, is it going to be the general dentist? Is the treatment plan not going to exist at all? We need to be thinking in terms of framework. We need to apply the framework. And if step 4 includes restorative dentistry and you say it needs treatment A and the restorative dentist says, no, I'd rather do it treatment A prime, well, fine. We just fit that back into the treatment plan. So we change step number 4, which we've created, and get the general dentist input on what step number 4 really needs to be in order to be able to accomplish that. So we're establishing the entire framework, the outline, and each of the individual practitioners put their points in there.
Now, I know what some of the periodontists are thinking.
What's that?
They're thinking that some of the dentists that refer to them don't like them to do that.
Yeah.
That maybe they're going to rock the boat, or maybe they're going to make somebody mad and they won't refer to them anymore.
Yeah, and we're all fearful of that. And of course, part of this is communication. And so we want to communicate with the general dentist in advance. If you're not doing this already, we want to communicate with the general dentist in advance to let the general dentist know that we're going to supply the structure. They have every right to put what they want into the structure and change it, but we let them know in advance that that's going to occur. Now, there's some critical things here, and you may not like what I have to say. If the general dentist is telling you only look at the implants but not look at the perio, that's the reason that we need to become directors of dentistry, okay? We can't just skate and think it's going to be okay. Well, I won't bother him too much. No, you can't think that way. We're thinking in terms of director of dentistry because, frankly, we are. There is a lack of true thinking and treatment planning going on. There's a lot of patients who are underserved. Ask me how we know. How do we know?
We hear it. We live it.
We live it. So, and if you're only thinking about referral source, frankly, you're seeing this population.
Yes.
There's all this population out there that don't know that you can help them. And they are desiring help. And so, yeah, if we open this up a little bit and you develop a treatment plan, never can tell what happens when you see that first patient says, I was never treated like this before. I was actually given an entire game plan, and who knows?
They're prepared, they don't feel overwhelmed, and they love when we tell them and you explain to them, I'm going to do this portion, and your dentist is going to do this portion, and we're going to refer you to so-and-so and do this portion. And we are organizing it, and we're making it happen. We're making the phone calls. You're telling them, I'm going to call Dr. Smith, and I'm going to explain this to Dr. Smith, and we're going to work this out together. They like that. They feel like they're taken care of, and they don't feel overwhelmed about the whole picture, which a lot of times it's big. It sounds big anyways.
Yeah. Good. Let's go to item number 2. Training in and of itself does not qualify anyone to simply declare himself or herself a director of dentistry. So just because you're trained doesn't mean you're it. You actually have to apply these principles. You just can't put a sign in front of your office. I doubt you'll do that. But you can't just put a sign in front of your office. I'm the director of dentistry. It doesn't make any difference. I don't put a sign there that says I'm the director of dentistry. I act the part.
Yes.
And that's what you're going to learn. Or you're learning already. Those of you who are members of the AIP for this long period of time, you've actually started to make that paradigm shift. Some of you have made complete paradigm shifts. It all comes from you, but it's actions, not training. Okay, item number 3. The biologic training that a periodontist has potentially puts that specialty in the best position to determine what teeth can be predictably saved and which cannot. That training may improve the likelihood that the periodontist ultimately qualifies to be a director of dentistry. So we've got the initial training, okay? Now, once we have the initial training, the biological training, just a matter of carrying it out just as we've discussed. Item 4, the director of dentistry in a small group practice, okay? So think small, 1, 2, 3, 4 doctors maybe. The director of dentistry in a small group practice must learn and practice communication skills so that the patient can understand the difference between a top-tier practice and the potential competition from a lower-tier practice. The difference must be real, not imagined. Okay? So those of you who are familiar with corporate dentistry understand that this is very much a numbers-driven game. It's not necessarily for the best interest of the patient. Talk to somebody who works in corporate dentistry and you'll understand that. Whether you talk to a staff member, or whether you talk to a doctor, okay? So understand there's that there. Up here, it's best for the patient no matter what. Now that may be a more costly treatment plan. It may be a less costly treatment plan. After all, how many times have patients come in to see you and scaling and root planing was recommended for 4 quadrants and you look at the patient and the patient has 4 5-millimeter pockets? Understand that it's lesser or more depending upon what the patient needs. Obviously, the patient needs a lot less than what was treatment planned for. It's no longer what do the insurance codes cover, it's what's best for the patient.
In this season, we're going to elaborate a bit more on number 4 here because patients don't know unless they know. They don't understand the difference between you and a lower tiered practice. They don't understand what they're going to get from your practice and corporate dentistry. So we're going to go over more of how you can educate your patients so they do know the difference and they do understand what they're paying more for. They do know that defined difference between you and the other people out there, whether another periodontist or a general dentist or corporate dentistry, whatever it is. We're going to work with the members this season to make sure that you get that information to your patients in a written form, in a verbal form. You and your patients and everybody is working towards that, because patients don't understand that unless you educate them.
It's true. But once you do educate them, or once they see what's there, and once they see the differences, we are going to talk about differences. I mean, they're defined differences.
Yes.
But once they see that, they will never want to go anyplace else.
Right.
Okay, we are number 5. The director of dentistry in a small group practice must also learn and be effective with business skills and marketing skills, or have people in those positions who have those skills. So understand that a director of dentistry, yes, if you have a good referral group and your marketing and business skills or your marketing skills have everything to do with that referral group, then by all means maintain that. Augment that if you can. I propose to you that may not be the case in the future. For many of you who are looking at this, know that in fact that's not the only place you can get referrals from. But understand that I don't do the marketing. I really don't. I mean, at one time I did all the marketing. I've learned all those things. But there are professionals who do marketing better than I do. I do the marketing in terms of hiring those professionals. I listen to what those professionals say they can do, and then I monitor them, or I have a staff member monitor them, making sure that the statistics are where they need to be based on that marketing. And if things are working, good, we plug more into that marketing. If we don't, then we jettison that marketing company and move to another marketing company. We don't do that quickly. It takes a while for things to catch on. But a while doesn't mean 2 or 3 years. A while may mean 3 months, 6 months, something like that. By that time, you should know whether the marketing company is really doing what you needed to do. But the only way you're going to do that is to have tight rein on the statistics.
That's another one that we're going to work on a bit more this season, is marketing. I've heard a lot of our periodontists that are asking for help in that marketing. They have been referral based, and they have been depending on that for many, many years. They can see the decline of referrals. They're feeling that the fear of what's going to happen when they're all gone or have a lot less. So we're going to go over a lot to direct-to-patient marketing, what we do, the growing pains that we went through, where we started, where we are now, who we use, and also have some guest speakers on that. So it's another one that we're going to elaborate on this season.
It's true, and it's also business skills.
Sometimes we say, all right, somebody else handle the business. Well, right. I ask you to handle the business, but I also ask Eleanor to handle the business.
Right.
There are others we ask to handle the business, but still,
you as the doctor need to be on top of the business. This is a business. Understand in the future you're competing with, and some of you are doing it right now, particularly in the larger cities, you're competing with well-oiled business machines. And you have to become one too. It is no longer the mom and pop idea. I'd love it for it to be the mom and pop idea, but it isn't. We've got to harness business skills, and we need to know every part of that business and monitor it appropriately, not from the accountant statement at the end of the year, week by week, month by month. See where your stats are so that you can make appropriate fine-tuning changes, not sudden changes, but fine-tuning in order to be able to allow that practice to continue to grow. Right? Where are we?
Number 6.
The director of dentistry must be able to treatment plan effectively, and for the vast majority of cases be able to sequentially deliver a treatment plan with minimal lag time between the examination and the treatment plan. What does that mean? It means you need to be able to treatment plan at the chair.
On the spot.
On the spot. You're looking at me saying, well, I need time to think about the case. Well, if you need time to think about the case, I want you to reduce the number of cases that you think you need the time to think about, because you don't need to think about most of those cases. If you're using that as an excuse, you're reducing the number of patients who accept treatment in your office, plain and simple. That includes those you need to talk to the general dentist about. I'll see you in 2 weeks. It includes all of those, because this is a play. And a play starts at the beginning, it goes to a nice crescendo, and then it drops off to a nice Conclusion. When you're doing your examination steps, when you're taking the particular 7 steps that we recommend you take in the examination, you are building the patient up to a crescendo. You can't drop the patient like that and say, I'll talk to you in 2 weeks. It doesn't work. What happens in those 2 weeks? There are other crescendos that are going on. There's the car that needs to be repaired. There's the roof that leaks. There is, I've got to pay more for Johnny to go to school. Whatever it is, that crescendo is diminished by somebody else's crescendo, and you've dropped the treatment plan. Can't do that. So you need to be able to treatment plan every single case of the chair. Are there exceptions? Of course they are, but don't make the exceptions the rule. 97%, 96% maybe, of the patients that I see are treatment planned to the chair. I don't have to think about them. It may be easier for me, because I've been doing this for a couple of years, but I always did it. I always had the intention to do that. And you have to have the intention to treatment plan the patient to the chair. How much easier is it for you when I've given the treatment plan and I tell you to make financial arrangements?
Oh, a whole lot easier. And patients like it better too. They came prepared. They want to know, they want answers, they want to know options. And even if we're not giving the exact options 1, 2, and 3, choose one, at least you're giving ideas of options 1, 2, and 3 so that they know what you're thinking and come back in 2 weeks after you've spoke with the dental dentist or the prosthodontist or whatever, did the wax up. So you are preparing them for their options, if not giving them. But most of the time, I would say probably 95% of the time, you're giving all the options.
Okay. If you can't do it 95% of the time, you know that's your goal. Okay? Good. Number 7?
Yes.
The director of dentistry must have regular doctor meetings with his or her colleagues with the goal of refining and improving the skills in number 6. So number 6 is being able to treatment plan the chair. So, I mean, I've got it great. I do. And someday you will too, if you don't have it already. I have a periodontist and a general dentist working with me. Listen to that, folks. There are 2 periodontists and 1 general dentist. Oh, I thought you need 6 to 8 referral sources and a few others in order to be able to make a practice. Well, then tell me, how am I doing it with 2 periodontists and 1 general dentist? And by the way, we're working at this stage right now, we have another general dentist starting part-time this week. Okay? One-on-one can make it if you're focusing on what's best for the patient. You don't need to have all of these referral sources. So, but the way it happens is I meet with my son, I meet with Matthew, I meet with Michelle and Matthew on Thursday morning, and they train me. So, for example, on Matthew, I may have programmed a patient, I may have said you need a 3-surface filling, and Matthew comes to me and said, hey, Dad, that patient needed a 4-surface filling. Good. I put that into my internal computer, so the next time I'm doing the treatment plan, I'm doing a better job. Could be something more major than that. You treatment plan this kind of crown and bridge, and listen, this is what we found out later on. All right. We learn from those experiences, but the only way that happens is for us to have regular meetings with our restorative doctors, whether they're in-house or whether they're far away, and they can be online meetings. They don't have to be in-person meetings at all, particularly with what we have available to us with digital technology now. We have to continue to refine that model, because the goal is, again, go back to number 6, get that patient treatment planned on the day you see that patient for examination.
All right, number 8.
One of the purposes of the director of dentistry is to create other directors if and when they show the wherewithal to do that. So our goal is not to just say, you're a director of dentistry, you're responsible for the periodontal profession too. And part of having a successful periodontal profession, and by the way, it did not begin with me. It began years and years ago. It begins with Dr. Morton Amsterdam as being a very good doctor to emulate, that he was in charge of the entire treatment plan too. Okay, we may be putting it into a different business model, but the idea is that you're responsible for that. But once you're responsible for that, then train the next periodontist to do exactly the same thing. Number 10, the director of dentistry should understand the talents of his or her doctors and staff and know when referral is the better choice. He or she treatment plans and refers always in the best interest of the patient. Okay? What does that mean? I can do that is not necessarily mean I'm the best qualified person to do that. Oh, I can do minor tooth movement. Well, there might be an orthodontist who might be better suited to do that minor tooth movement. I can do the endo. Well, listen, endodontists do endo every day and they use microscopes and they really, they know what they're doing. Okay? We refer out if it's in the best interest of the patient. And it has nothing to do with finances coming to you. It's what's best for that patient.
Right. We're going to do this one.
Oh, I missed one.
I wasn't going to say that.
Thanks. Okay. Competence in all of the above is the primary criterion for success. So, we talked about treatment planning, we talked about director, we talked about business, we talked about marketing, we talked about all of those things. Competence is what determines whether you're being successful or not. Okay, now, number 11. In large group practices, now this is not the small group practice, this is the large group practice. In large group practices, it is possible the director of dentistry is involved in diagnosis, treatment planning, and treatment only, with the business aspect of the practice given to those who are competent in running those practices. So eventually, okay, you go from one-person practice, two-person practice, three-person practice, and now you've gone to a 10-doctor practice. There may be another person that you can hire to run the business aspect of that. That doesn't mean that you're not in contact with the person who runs the business, but you no longer have to have the head for business as long as the person you hire has the head for running the entire business. So eventually we are going to larger group practices. Why? Because that is the trend in dentistry. When's it going to happen? I don't know. In some cases, happening very, very quickly. In other cases, may be several years. But no matter where you are, don't be satisfied with where you are. Always look for what the next step could be so that you're prepared for that step if you need to or if you want to take it. And finally, the director of dentistry directs treatment and is ultimately responsible for the quality of care rendered in the practice. His or her decisions to accept a particular treatment pathway or not are solely determined by what is best for the patient. His or her decisions to accept the final product of treatment or not is also solely determined by what is best for the patient. Okay, so listen, just because you make more money in dental implants doesn't necessarily mean the dental implant is the right procedure. You know that. You wouldn't be members of the AIP if you thought any differently. Okay, but what happens when a patient comes back with an open margin, with a crown that's not an occlusion? What happens?
Send them back.
Send them back. That's the agreement you have with your general dentist, whether in-house or whether in another location, that if the quality of the work is not, the term these days is sustainable, I'll use that. If the result is not sustainable, if it's not a result that you're proud of, then redo it until you are proud of it, because patients will perceive that, will know that, and will refer other patients to you as a result of your integrity.
That was one of the best things about becoming independent on that as well, is you get to pick who you're working with. So you don't have to work with the guy that doesn't want you to do a full treatment plan. You don't have to work with the guy that does really bad margins every single time. You can pick and choose who it is you're working with. And I think that was probably your favorite part about this whole thing.
And I saved it for
yes. Yes.
So that's it for the 12 attributes of the director of dentistry. This is something that I want you to look at this. I want you to take it to heart.
We hope you have enjoyed this video. If you have any questions in regards to it, please email us.
The American Association of Independent Periodontists is there to help every periodontal practice do better. I'm Dr. Lee Sheldon.
And I'm Danielle Joyner. We'll see you on the next video.